Hi, so this is Seb. Welcome to a new thing. So we're going to try and deliver a session that I love to have a bit of interaction with, all from our socially distanced spaces, and hopefully this works out okay. So what was going to be a longer session, we're going to break up into chunks and do a bit each day. So this lets you hopefully have a look in your own time, at your own pace when suits you, because I know that time is something we don't all have so much of at the moment. So what am I talking about? Well, I've called this becoming a First5 GP. Now, if you didn't know, a First5 GP is what you become for the first 5 years after qualifying as a GP. It's pretty self-explanatory, isn't it? The reason it's got a name is that the RCGP, both the national and local branches in each of the regions of the RCGP, offer greater support for people becoming a First5 GP. And the reason I think that's important is if you think about your friends and colleagues who are in other specialties, they'll kind of complete a lot of their exams around the ST3-4 level and then spend several years working as a senior registrar developing their specialism. Whereas in general practice, we kind of do our exams at ST3 and then actually launch into the world as a consultant equivalent. And that can be pretty scary. And I think no one would think any less of you for thinking that thought was scary. So part of the aim of today is to talk about some of the things that hopefully you weren't aware of in terms of how general practice works, to talk a little bit about uncertainty and the principle of resilience, and also to talk about some ways of boosting your confidence and remembering why you went into this job, because especially as this year is going to take longer than we all expected, I think it's really important to remember why you went into this job and chose it, because you did choose it. And I think sometimes especially on a bad day, it can feel a bit like, why have I done this? Okay, so as a session kind of plan, what we're going to go through are looking at where some challenges for general practice might come and identifying those, talking about the concept of resilience and how to apply that, then changing tack a little bit, looking at how both general practice and the NHS hospital contract work with relevance to your future life as a GP. Then to finish off, there's a section on putting the pride back into your practice. So this is based largely on a session that I've attended by Roger Neighbour, who you might remember from all your medical school and GP training communication sessions. And lastly, if you've never done it, I'm going to try and take you through a mindful exercise, something similar to what I do myself and I do with my patients, I think quite successfully. Okay, so first up is thinking about the challenges for general practice. Now, what I mean by this are, what are the external factors that are out of our control that can affect how we work and will affect how we work in the future? So I'd like you to just start thinking about what kind of challenges you can foresee general practice facing, and perhaps a way to do that is to think back to GPs maybe 20 years ago and how general practice looks now compared to then, and whether any of those changes might have been foreseen and how you deal with that and prepare for it. So I've tried to group these a little bit into categories. Now this won't cover every single challenge, but I think these are some that are useful to think about. And I'll go over each of these in a bit more detail. So the three categories I've chosen are technological changes, so technology, IT systems, computers, political changes, so that's both the sort of general politics as it affects the whole of the nation and world politics as it affects the world. Also the kind of political changes that happen more locally, so politics within a practice, within a group of practices like a primary care network, between primary and secondary and tertiary care, between CCGs, NHS England and all those other kinds of bodies. And the last group are the socio-demographic changes that we can foresee happening. So that's changes within our population of patients that we see. So let's talk about some of the kind of technological changes and think about what areas change may come from in that sphere of influence. So first up, I mean, obvious, isn't it? It's the internet. The internet has everything on it. The information is all there, and if it weren't for the fact that the internet can't yet synthesize that information, you could almost argue, as some health ministers have tried to do, that you don't need doctors. The information's just there to be found. I think the critical bit there, though, is that is what our job is. As doctors, we are and have always been synthesizers of information. So we gather information from different sources, synthesize that into a problem, management plan or whatever, and then we share that with the patient. It's just that instead of having learned and acquired knowledge through books, it's now available to everyone, and that means our patients may well have looked at information before they come to us. That's really important because I think we should always acknowledge that we're using the same source of information as they are. It's just that perhaps we've had more training in the appraisal of how good that information is. I always think back to when I did anatomy at Manchester University. That may come as a surprise to any of you who was at Manchester. But one of the things that the anatomy demonstrator told me, which I thought was fantastic, which was it doesn't really matter that I learn the names of the muscles and where they insert and originate from, because unless I'm going to be an orthopedic surgeon looking to operate on that part of the body, it's not information that's worth taking up the limited space it's in my brain for. So actually far better that I learn how to find out that information, to verify that it's true, and to access it when I need to know it. And I think that skill is something that we really must praise in ourselves as doctors, and especially as GPs. Something that seems to be more used now than perhaps only a couple of years ago is the use of mobile phone apps for health data tracking. So there's the idea that everyone will be on the NHS app for booking appointments and making access to general practice. A lot of you might now be using AccuRx as a way of talking to patients. There are plenty of medical apps that we use and that patients can use to access or monitor health services. I will say I still hate the any fitness type tracker thing, which patients seem to love coming to show me their data, which to my mind often seems to indicate just times when their watch has come off rather than periods where they appear to be dead. I'm also fascinated by, I think it's Samsung Galaxy, which appears to have a SATS probe as part of its camera function, which I just cannot understand how it would work. So I was really pleased to see in recent reviews of data around the use of home monitoring because of the COVID crisis, that the apps are not medically rated and supposedly don't work very well. Their range has got such a large margin of error that any SATS rating could be up to 9% more or less than what it tells you. So moving on to another area of technological change, I think a large one here is about the access of patients to their own records. This is something that they've been able to do for quite a long time, but the electronic records make that far easier to do than sifting through letters of, delightful quality. If you ever get a chance to look at patients' old notes, there can be some really choice letters, especially from psychiatrists, I find, when you delve back into the sort of 50s and 60s. Because of course they were never intended to be read by anyone than the doctors. Communication is very different, and patients now have that access to their records. And that probably means we have to change a little bit how we treat those records. So knowing that the patient can look at it means we have to think about our language. But I think even more than that, things like, say, labelling a blood test as normal may not be sufficient information for a patient who can view that record online and doesn't think it's normal or doesn't understand what we mean when we use the word normal. When we use it, what we're actually saying in medical language is this result is within the normal range. What patients often hear when we say normal is there's nothing wrong with you, and patients really hate that, don't they? And this for me is an example of where the change in technology, so the availability of electronic records, has had the effect of allowing people to be able to look at their records more easily, which then has the ongoing effect of having us needing to modify our language so that the patients can understand the record that's there. I somehow doubt that anyone was thinking about this 20 years ago when the idea of computerised records was still quite a new thing. Next up is something I think we'll see increasingly, and indeed many of you will already have experienced this. So there was one particular sort of prompt that used to come up when you typed in hay fever on System 1 that forced you to go through a sepsis protocol because the word fever had been activated, which was an example of how risk software perhaps wasn't quite as good as it had hoped to be. But I think there are lots of things such as script switch warning you about interactions between medicines. And actually, what do we do with that data? I've talked about a significant event in my practice where actually the sheer number of alerts that come up on medicines mean that I probably don't read them all properly. And certainly something like alert fatigue is a known quantity. So we have to be really careful about software helping us, but taking care that it doesn't hinder us as well. Sort of linking to patient records and risk software is the idea of insurance. And I think with more data and recording, I think the nature of our medical indemnity is going to change yet again. I don't think it will be long before consultations will be recorded either in audio or video form, and certainly many patients want to do that already. By the way, they're allowed to do that if they want to. What they're not supposed to do is to share that information on any kind of social media or public platform. But it's not necessarily a bad idea for patients who might struggle with memory or just want to have the advice there to listen to again. So I'd encourage you to think about offering that as a service in select situations. I think from an indemnity point of view, it probably results in us working in a more defensive way than perhaps we already do. And depending on the generation that you've qualified as a doctor, I think you'll have seen lots of changes in how doctors have kind of gone from being able to get away with things because patients kind of just looked up to us as gods who could do what we wanted, and if mistakes happen, it's because we meant that to happen or there was no way we could have done anything about it, to a culture that's perhaps a lot more sort of concerned with the idea of, well, lots of mistakes are preventable and we should try and do that with things. So those are some changes that I think have already happened, but the last two are topics that I think are perhaps more incoming rather than experienced. So the idea of artificial intelligence, so using software and technology to actually make diagnoses and get things right. We've probably all read stories about Babylon, the GP at hand provider who uses a chatbot to diagnose various things. And there have been some sort of viral posts where it gets things wrong, although I suspect there's many occasions where it gets things very right too. I think the difficulty with medicine and what we need to remember to sell ourselves as is that as doctors we still have the best computer in our brains to be able to synthesize information that no one's really been able to replicate on a good enough basis yet. But it may well be that the use of AI in triage might be something that starts to happen. So we'll start seeing patients who've already answered loads of questions from a chatbot, say, before we even lay eyes on them. And lastly, this one's made me laugh. I sort of wrote this presentation quite a while ago and have updated it. And I used to talk about telemedicine as if it was sort of a thing that might come in the future. Wasn't sure whether we were going to use it or not. And yet now I go to work and it's the mainstay of how I operate. I don't know how much to say about this really. I don't think any of us would have conceived 6 months ago that the NHS IT infrastructure would be able to support such a massive change to remote working. You know, in my practice, we've now got most GPs working from home on many of the days. I personally have found that I'm able to do way more than I thought I could do on the phone quite comfortably. I've used videos and photos via the AccuRx app. I know there's lots of different kind of things available. But telemedicine, I think, is really going to change how not just we as GPs work, but I think how the NHS works in total. You know, some areas like NHS Highlands have used this for ages because you just can't have specialist visits in every island up in the Outer Hebrides or whatever. But it's not something we really embraced in the rest of the country, and I think that's very much set to change. I think that's that important when you think about why you became a GP. And something I know I found, and maybe you have too, is that I'm really sort of missing the human contact. One of the things I like about general practice is that I feel like I'm a specialist of people, and it's just a bit odd when you've removed the people from me. So I'm a bit reticent to the idea that I might work purely remotely in future, though I can totally see the benefits, and it has changed very much how I work. So more political type changes. I think this is the kind of thing that we could talk about as a group for a long time. So I'm going to try and condense this into things that I think are relevant to think about in terms of how we will work in future. I think first up is we can't ignore the idea that we're forever being asked to achieve more for less. So do less referrals, manage more in community, prescribe less things, get better diagnoses quicker. The drive will forever be endless, and I don't think that's ever likely to change actually. Doctors of every generation will report the same kinds of strains. It's just that the technological changes of the time or sociological changes of the time focus where that achievement needs to be made. In sort of line with that, the RCGP and other sort of top bodies have looked at, well, what does general practice need to look like? And that's where the general practice forward view comes through. It's probably worth having a look at some point. It's useful to see what our leaders think our future career should look like. And I think there's no sort of disagreement for anyone really that the future of NHS healthcare delivery in the UK, or England and Wales I should probably say, should be very much community-based medicine. So the idea that we take more and more out of hospitals, manage more and more in the community. And that's not news to anyone who's worked in a GP practice. You know, we deal with every single thing that comes through the door. The only place that's similar is sort of an A&E type background, except we don't get to discharge them after 4 hours, we have them for life. And figuring out problems over a lifetime is an amazing thing really. It's one of the reasons I probably like being a GP, because I like to see things develop and I like to get to know the people who've got those conditions. NHS funding is always going to be something that is at the whim of whatever government of the time, and I think with the coronavirus crisis it's really shown how important people value the NHS, and perhaps how much they're willing to fight for that to be better than what it is currently. But let's make no bones about this, the demand for healthcare is always going to outstrip any possible supply. There are so many big questions, I think, around what the NHS should and shouldn't provide, and as more and more new and expensive treatments come along, really difficult decisions are going to have to be made about how we decide what's funded and what isn't. And aside from all that, I think what's really important to think about is perhaps sort of more NHS England and primary care based changes. So the model of general practice as it currently sits, so patients book an appointment with a receptionist to see a GP who then deals with their problem or refers onwards to a specialty, looks likely to become something of the past. And I think what we will largely see is the roles of GP diversifying more. So you'll still have GPs who provide services like that, so clinician type GPs who see patients, but I suspect a lot of those patients will already have seen another type of healthcare professional, usually lower paid, therefore cheaper, and will only get the most complicated or difficult of patients to see. So the days of contraceptive and blood pressure checks might be long gone. In many practices that's already the case, I have to say. The sort of future general practice model is more akin to that of a hospital actually, where you've got a consultant making changes, but you've actually got a series of minions around them doing a lot of the other bits of work which the consultant ultimately has to make decisions about. And I think we're likely to see more and more of that happening in general practice. Most of us will work somewhere where there are allied health professionals doing parts of the job, whether it be healthcare assistants doing health checks, your HIPs doing lifestyle advice and training, whether it be advanced nurse practitioners functioning much like a GP, or the first contact practitioners, so in musculoskeletal and mental health, doing work that would have been considered a GP's only 2 or 3 years ago. I think that's then important to think about, because as a GP, in terms of your future development, you need to know what it is you like about general practice and what you want to get out of it, because not everyone will need to be a commander, sort of sat in the chair while various professionals ask them opinions. But if that's something you're interested in, then it's important that you start to develop those kind of abilities as well as your clinical kind of knowledge. Now lastly up is our kind of socio-demographic kind of strand of change, and I think not much of this will look too surprising to you. We're really looking at a change in how services are provided, because more and more as a proportion of our patients are elderly with increased conditions. More and more conditions are treatable but with considerable morbidity. So I always think heart failure or COPD are really good examples of this. Drugs make people live longer, but they're often quite unwell a lot of the time compared to people who we'd consider to be well. The role of preventative medicine is often lauded as something we need to do more of, and certainly within things like COPD and heart failure, that push to stop people smoking, to think about heart attacks and treat them early, makes a real difference to the long-term effects of those conditions. Defensive medicine is something that is really difficult to avoid as a clinician. I think especially as a new First5 GP, the worry about making a mistake and it coming back to bite you can be really frightening. It can be disabling actually to a career. I suppose what each of us has to do is find the line that we're willing to work to, and make sure that we've got people around us that will tell us if we're doing things too much or too little, so working too safely or unsafely. I think some other factors that are really important to consider are a lot of our social care kind of model is based on the idea that people will look after their families. But this may not be the case. We have increasing numbers of single people, of generations of family who will be quite old by the time their parents need care and may need care themselves and not be able to handle that need. We have families living apart across the country. And given that integration with health and social care, it's a real challenge, I think, for people who make policies at higher levels than any of us probably will ever do, to figure out what on earth we do. And I think last but not least, something that's really important is to think about the workforce expectations. That's what you and I want to do with our lives and our jobs. I don't think many of us really want to be like GPs of old, working 7 days a week, 24 hours a day, doing our own on-calls, loving our patients, but having a very different relationship with them than perhaps we do now. Most of us see being a doctor as a job primarily, which we probably enjoy, but isn't necessarily all of our life. And that isn't perhaps how the public always sees us as working. And from a workforce planning point of view, changes very much how many people you need to do things, giving rise to the headlines you see every few months in every bit of press about part-time GPs ruining everyone's lives. And to that I would say, from my own personal experience, I work technically as a part-time GP, and my hours per week in the various jobs I do number just under 40 hours a week, so pretty much a normal person's full-time working week. But in general practice that equates to me being in just 2 days a week, which patients love to remind me of. What they don't see is that I need that time to rest, recover and live my life as I want to. And yeah, I could earn more money by working twice as many clinical sessions a week, but I don't need that money to enjoy my life. And these are all decisions that we all have to make about what's right for us. So what's the point on my little lecture about the causes of change that we're going to see? The point is to recognise that there are so many things that are out of our control that we don't know what's going to happen. So a big part of our future career planning and life planning has to be around accepting uncertainty. I know you've done some sessions on this before, so I don't want to over dwell on this really, but I think it's a really key point to recognise, both from a clinical perspective with patients, but also from a life planning perspective. You don't always know what's going to happen, and therefore the biggest challenge I think is learning to kind of be okay with that. Some tips then on managing uncertainty. Well, I think, it's okay to not know everything. I take quite delight in telling patients when I don't know something, but I know where to find it. And actually, if you can show the patient that you're honest, you're not an idiot, and that you're looking up clever things. So, I'm like, I know there's a guideline that tells me how to do this, but I cannot for the life of me remember what it says. I'm just going to check. If you can find that guideline and then give them the information from it, well, you've proven yourself, haven't you? Because you knew it was there, you just didn't know the detail. And people can see how big our BNF is. They know the internet is full of information. So make sure it's okay to not know everything, and you don't have to pretend that you know everything in front of a patient. Having said that though, I think it's really important that we don't transmit our own anxiety about not knowing things to the patient. So it's about being confident. So I don't know what this is, but I know where to find it out. And really being key on what the patient wants to get out of the consultation. So I'm really sorry to say it, but the ICE stuff is so important. If you know what the patient's worried about, and to some degree if they know what you're worried about, actually that consultation resolves much better and leaves you both in a position to trust each other. So rather than saying something like, I've no idea what's wrong with you, maybe change that to something a bit more positive. So perhaps, I can't figure out what's going on with you now, but I want to arrange for some tests and do a bit of reading to see if I can figure out how we can progress this so that you feel better. Now, of course, one way to avoid any kind of problems with patients is just to refer everyone you see, do tests on everything that touches you. And whilst that's sort of okay, it's going to generate you an awful lot of work. And one of the problems in the long run is if you do tests when they're really not necessary, just to make yourself feel better, the patient sort of learns that that's what you need to do every time. So when it doesn't happen in future, they'll be worried and expect the same again. So it's a really difficult balance to kind of achieve. So I think a lot of the time it's about acknowledging what you're doing, discussing that with colleagues and friends to figure out ways out of that. Understanding why you're worried is a really important thing. And you'll know from my kind of discussions and talks with you before, I'm very much about knowing and understanding yourself. If you know why you're doing what you're doing, then actually you can generally find the way out of it. And so with this slide, we'll conclude today's kind of half-hour session on managing uncertainty with a quote from a philosopher called Epictetus. I'd like to have met this guy. I feel like he's one of the most chilled people ever. The principle is if it's not in your control, well, you can't do anything about it. So the next session we're going to talk about, well, what can you do about things that are within your control? And that's where resilience comes in.